Welcome, everybody, to another episode of the Serdentity podcast. I am your hostess, Elizabeth Dewar Anthony, and today I have with me Walt Fritz, who is a physical therapist, but he's also an innovator and a disruptor and
Ah,
an agitator. And Walt has lots and lots of experience working in the oral facial complex, working with the tongue and vocal disorders. So I wanted to talk to him today so my fellow dental professionals can get a better understanding of the neuroanatomy of the area that we're working in, and also talking about ways that we can work together to improve the patient experience. Hi, Walt.
hi, Elizabeth. Boy, that was an introduction, a disruptor. Wow, I'm gonna have to I'm gonna have to own that one because yeah, I guess I am in a way. Maybe not in the specifics of what your field entails, although some of it, right? But in general,
Oh,
yeah, I
yeah.
guess I am. I guess I am a disruptor, and I look
Oh,
so mild. I look so mild-mannered, don't
I
I?
know you.
Yeah.
Mild mannered Clark Kent. Um,
Yep.
but the things, your posts on Facebook, you're definitely, I think, a disruptor because you are challenging long held beliefs in your field, and that's kind of what I am doing in my field. Challenging these long held beliefs that create, well, suffering. Create, I see in my field lots of suffering on behalf of both patients and professionals, um, because patients approach the dental appointment traumatized, therefore they're super reactive, therefore, and then you have the patient reacts, the provider reacts to them, and you get a downward spiral. And next thing you know, they're posting about it on Facebook, complaining about these
Yeah.
awful patients. So I, I've always known that there was a post traumatic stress component to that situation.
Yeah. Yeah.
It wasn't until I became a myofunctional therapist that I realized, oh my God, it's the airway. When
Yeah.
people can't breathe, they become traumatized. So anyway, I want to hear from you about your experience working in the oral facial complex, and your observations on everything I just said.
Yeah. You know, we're there's a lot of overlap between, well, what you do, what you look at, what you've learned, and I'm sure the broader perspective of the people who might be watching this interview that you were kind enough to invite me in on, as well as how I work and what I work with. I'm a physical therapist, but I teach continuing education to a wide range of professionals, dental professionals, malfunctional trained professionals, speech pathologists, massage PTs, OTs, a lot of, and then other folks. But this is a core part of what I work with, what I teach. And so many people come to my classes with a view that, okay, I'm going to learn a new model of intervention, which is certainly true, right? Working with base of tongue, working with tongue flexibility, with posture, with airway, but also with the jaw itself in terms of the pterygoid. Can we get maximum mouth opening? What's maximum
Mm-hmm.
mouth opening for this person? What does it feel like to try to go to end range maximum mouth opening? Not just the pain of it, but
Mm-hmm.
then the psychosocial aspects of past and present when full mouth opening is asked to be achieved and sustained. I mean, I think there's a huge amount of crossover there. And yeah, when I teach a class, I am teaching techniques. Yeah, we're learning ways to, at least what the evidence tells us, improve maximum mouth opening, diminish discomfort, pain, of what it feels like, improving airway. But it's also about that's inclusion of what I use as the phrasing is shared decision making.
Mm-hmm.
It's a rarity in manual therapy where the patient is asked to and expected to participate in a meaningful way. And every time I've been in a dental experience, shared decision making is not typically a part of it.
Not at
I
all.
get, And I guess I'm going into some of the softer pieces, not,
Sure.
not should I drill your tooth, not should I, cleaning. It's not about that. And excuse me for being overly simplistic,
Not at
but
all.
it's about what I just explained to you. Does this sound safe to you? Does this sound like something we need to modify both beforehand and during? We stop when someone's in pain often, but how do we deal with that? We stop when somebody expresses fear or hesitancy, but how do we deal with that? And I think that's where the mutuality of what you teach and do and what I teach and do, could have an influence on your audience here.
Absolutely. Um, and what I have observed in my 35 years in the dental field is that patients are already in fight or flight when they walk into the dental office. And
Mhm.
many times that does not present as fear. It will present as agitation, behaviorally as belligerence, as argumentativeness, and sometimes downright uh, almost threatening because the patient is so defensive.
Right.
And I, what I want to, and I love what you're talking about. It's the softer things. It's not, and dentistry is so technical.
Yeah.
So it's the softer things. It's Serdentity is about how do I approach these people,
Mhm.
and serenity is approaching the all these patients, but especially these difficult ones with equanimity, with no judgment, with a very calm demeanor.
Yeah.
And I'm trying to that's what I'm trying to teach. And I think it speaks very well to what we're talking about.
Yeah, it's ironic because I'm going to call it the manual therapy field, which is sort of a loose group. One might think that, well, manual therapist could be physiotherapist, physical therapist, massage therapist, but it's a broader spectrum of that. But I witness so much online on some of the online forums, for instance, on Facebook, that in a massage setting, the patient who comes in and wishes to contribute is often seen as a difficult patient, somebody
Mm-hmm.
who is well, they'll call it micromanaging or
Mm-hmm.
controlling the session.
Mm-hmm.
And while I sort of understand that buzz to a little bit, the therapist complaining to a group of peers that the patient's telling them how long to spend in a certain area or how to apportion the protocol for that session. And with a sense of complaint, how do I get my patient to stop micromanaging me? And
Mm.
there's times, Elizabeth, where I just kind of want to reach to the screen and say, and shake them and say, they're trying to help you help them by
Right.
meeting their values and expectations. I don't like aggressive work is often a complaint versus um, a true statement of what might be how you might better able to help them, and I could so easily related to my own, dental past, dental present. And
Mm-hmm.
if sometimes there is sort of that give and take of shared decision making. Do you prefer this or this? But I think we can do more, especially when you describe that person walking in a version of fight or flight. They walk into me, maybe not in fight or flight, but fully prepared. I call it stick biting, to bite on a stick while I kind of get their pain, get their problems out of them. And they're literally prepared to just put up with anything necessary. And often I'll say, well, how is this pressure? And they'll avoid the question by simply saying, do what you think is best.
Mm-hmm.
And well, that's nice. It allows me my input. But boy, as a human being, I think I should be asked, I should be included in what we do, not the technical aspects of it, but the psychosocial, the softer, the environmental, the interactive piece of our work, I think is so amenable to shared decision making, or at least moderate inclusion of patient preferences and values into what you and I do.
Mm-hmm. So the other night we were talking about ego and
Mm.
this supposition that I'm the expert, I know what you need. And in dentistry, we just seem to have elevated that to an art form. And
You're being sarcastic?
Uh, uh,
With because what you just said is a little bit confusing to me.
really, I was being sarcastic,
Okay,
but
good, good. Yeah. All right.
so that this I'm an expert, and don't tell me how to do my job.
Hmm. Hmm.
And I've certainly had over my years of working patients, patients that tell you, say, don't do this, don't do that, don't use the ultrasonic scalar, I don't like it. And I used to have a snappy comeback. Listen, I won't go to, and I would fill in wherever you work and tell you how to do your job. Okay,
Yeah.
if you don't tell me how to do mine. And guess how that goes. It
Yeah.
So I'm contributing to that negative feedback loop. And
Right.
it's I don't know what it is. Maybe because, again, dentistry is so technical that
Yeah.
it's so hard to put aside that I'm the expert.
Yeah. Again, we're talking about different concepts, but yet the issues we're talking about are identical, right? In my profession, a physical therapist might view a person's problems as a result of weakness. Well, we need to
Mm-hmm.
strengthen that muscle, right? Um, while there's a lot of gray area between you're weak and that's why your problem and why exercise helps. I think that even in something as simple as exercise prescription, the evidence is clear. If I'm better able to sort of gauge your interests, and you'll stand a better chance of complying with my suggestions as well as
Mm-hmm.
improving if I try to match my exercise prescription to your basic core beliefs of what you enjoy doing, what you like doing, what you might see acceptable. And the
Mm-hmm.
same thing as manual therapy, right? There are people who like me to be uber aggressive and don't feel like anything's being done until we get there. And there's other
Mm-hmm.
people on the other end of the continuum. The traditional way people see people like me is, well, I'm going to see the expert, so I'm going to let you choose.
Mm-hmm.
And my response is often, well, I appreciate that, that respect that you're giving me, but I know enough about the psychosocial, about the surrounding mechanisms at play here that I stand a better chance of helping you if you help me help you, right?
Mm-hmm.
Does what we're doing feel safe? Does it feel like it might be helpful? Is there anything about it you'd like me to change? Now, aspects of my work are certainly not the same as aspects of you and your audience's work, and I totally get that. I don't mean to conflate those,
Mm-mm.
but I think we can do better. We can do better, number one, to allow patient input, allow an understanding of past and present trauma or fear of trauma, whether it's from a dental experience or a manual therapy experience.
Mm-hmm.
It's not always easy to get them to open their mouth, no pun intended in your situation, but to actually share that. And I think that's where, in the little micro bits of time we're offered with patients, I need to spend that time wisely. And, that includes some warm up. And I don't mean warm up of the tissues, I mean
Mm-hmm.
warm up of us as having a therapeutic relationship.
Yes, the therapeutic relationship um, is so important, especially, well, in both of our fields, but in the dental office, es- that therapeutic relationship. And rather than like, I'm the expert, you're the patient,
Mhm.
coming together, and it's up to me, I think, to create that atmosphere. It starts with me.
Yeah.
Even if the patient comes in fight or flight, angry, you know, it's up to me to do what I can to bring that anxiety down, to bring
Yeah.
that negativity down. And it's and we are not taught this. When we are
Yeah.
educated in our professions, the psychosocial part of it is not taught. And so people fall
I,
back on their, well,
and their expertise, right?
right, on their expertise and
or ego. Yep.
on their ego. Right. I
Yeah.
need to, I need to um, control this. I need
Right.
to, and I think in a lot of dental professionals, it's fear based because we don't know how to. We don't know, if in my regular life, if I don't like anger, I'm afraid of angry people. How how am I supposed to react when there's an angry person in my dental chair?
Yeah.
So again, these are things that I had to learn sort of on the job, on the go.
Right. Right.
And but I did. It can't be that
Yep.
hard if I learned it.
Yeah. I think shared decision making is often sort of misunderstood. Um, if you're a surgeon, you're not going to be asking the patient, "Do you want me to put the suture here or here?" We're not talking about those, the minutia. And in some ways, it is sort of the softer aspect of it. But when you sort of dive into the literature of number one, your own profession, but of broader professions, shared decision making is becoming an expected norm
Mm-hmm.
in medicine, and I would probably extend that to the dental profession. The recognizing the value of the therapeutic relationship, and that goes back decades. One of my favorite papers to quote is a 1957 paper by psychotherapist Carl Rogers,
Mm-hmm.
where he presented a paper that really got him ostracized from his psychotherapist colleague, the profession, in that what he said was it's not the modality that creates psychological change. It's not your choice of the proper, I'm gonna simplify Reichian versus
Mm-hmm.
Freudian, right?
Mm-hmm.
That all of them can be and are effective if you build the therapeutic relationship. That therapeutic relationship was the key driver of change in the psychological realm, and there's been numerous papers, numerous studies that sort of transcend that it's just psychotherapy into other professions to show that the therapeutic relationship it's a key driver. And to
Mm-hmm.
me, in my model, the relationship is built through shared decision making, through allowing the evidence-based model to truly be sort of brought to the public in the way it was originally intended. The evidence, our experience applying the evidence, but that third part, which I think goes underserved, and that's patient preferences and values. How
Mm-hmm.
can we work toward elevating that to truly having one third of the weight in our clinical interactions? And that's a tough one for not just for PTs doing manual therapy or exercise, but in every profession. How
Mm-hmm.
can we elevate patient preferences and values? And it's so much more than just saying, "I'm not hurting you, am I?" Right? Those simple
Mm-hmm.
things. Um,
Mm-hmm.
and I got to be blunt, Elizabeth. I don't know. I've not taken a deep dive into shared decision making into the dental profession, into the dental hygienist profession, but I would wager that it is being represented in current as well as emerging literature as a key driver.
It is in some. By the way, I love Carl Rogers, and
Hmm.
it's, but it's still like more of a fringe. It's still
Yeah,
more of a fringe thing. And I have a good friend, Dr. Paul Henney, who has he's in Virginia, and he is one of the forefront people of exactly what you're talking about. And he has a conference. He posts educational stuff on Facebook. So the information is there. But again, it's getting dental professionals to to look. It's great that the information's there, but if I don't look at it, if I don't read it, then it doesn't help.
yeah. So can I put you on the spot?
Sure.
Um, you've taken classes from me. We've had interactions. I know you're applying some of this work with your malfunction work. How did the work that I potentially taught or presented to you, how did that influence your practice when it comes to the topics that we're talking about right now?
Well, it just reaffirmed what I already believed, and I think with your talking about when we talked about ego a little bit, I had to
Mhm.
kind of take a step back and say, all right, you know, how much am I, how much of my ego is working here? And am I doing this? I'm the expert thing.
Right. Right.
And one of the things I took away from our your course was, I was still working in clinical hygiene at the time, and just the sacredness of this area of the body and how a touch is so important, and
Yeah.
how much we communicate with our touch, whether
Yeah.
or not we think we are.
Yeah. And to me, that's been some of the most important learning I've done in the last decade. Not, are we able to reach a muscle? Are we able to loosen that muscle? All those things, but the affective qualities of touch, not just from a psychological perspective, but from a neurophysiologic perspective, right?
Hmm.
Contextually appropriate touch to the skin and underlying tissues, affecting C-tactile afferents, which are, that's a primary driver of trust, relaxation, etc. And that's only one of dozens and dozens of mechanisms at play when we touch. And everything you and I do does involve touch. There, therapeutic intent is certainly different, but we're talking about touch from the cognitive behavioral aspect. How does this touch impact the person? Do they understand why I'm touching them in the way I am?
Hmm.
Because, you could certainly turn off that C-tactile afferent pathway real fast if we do it too abruptly, without
Oh.
permission, not understanding the full reason why we're touching.
Hmm.
It's almost, well, there's a term I really appreciate. The more I learn in general, but the more I learn about touch, in that I used to think it was very denominational, right? I'm addressing your fascia singularly. Now I realize that's impossible, right?
Hmm.
I'm touching you as a human being. So if I'm aware of other aspects, other influences, positive and negative, that I can have with you, your receptiveness, your willingness to change, that's a huge impactors. It's soft. A lot of people want the clinical facts. Well, what muscle is that? How do we break that up?
Hmm.
That's a simple story. A lot of people talk about, and they still teach it. But there's so much evidence to say that our touch is so much more than just what we think the product is of changing that tissue. And we could extend that easily into the narratives of the dental work as well.
Hmm. Oh my God. Especially since we're working in the oral cavity, the most
Mhm.
sensitive area in your whole body. And I think that's a major key, is that dental professionals fail to realize that when you when you just start abruptly without establishing that soft part, that's
Mhm.
how people get traumatized. And
Yeah,
that's what contributes to this negative vortex. And that the soft skills, it skills, well, it's a skill, but it's even deeper than
it
that.
is a skill.
It's a skill. Yes, the behavior is a skill, but to me, it's like a mindset. It's even deeper than that. But we only have so much time. So
Yeah, yeah, and so I'm going to insert a story here, and again, I know that we need to move on, but especially when it pertains to working in the oral cavity, the oral region. I had a patient decades ago, and I tell this story at every class I teach, where this person came into me for hip pain. We're not talking about hips here. I totally get it. But she was coming into me for my expertise. She was referred to me because of the work that I do, the soft tissue work, right?
mhm,
So she was intelligent. She was fully sensate, fully cognitive, fully verbal. And I said, well, I'd like to work on the region of your hip using some of the stretching. Are you okay with that? And she said, yes, I am. And I went to work. I went to work from a very me-centric perspective. I isolated the area. I found the barrier, the tightness, the tension in the hip region, and I went to work to remediate it.
mhm,
And I looked up, and because previously, as I did back then, I said to her, as well as everyone I saw back then, if something is too much, tell me. So I'm working, feeling like I'm being effective based on how I was trained. And I look up and her face is all scrunched up in pain. And I
Mm-hmm.
asked her, I asked her, is this too much? And she raised her hand and said, please don't do any more than that. I said, well, okay, please let me know when we get close to that. I don't want to take you there. So what happened over the next 15 minutes was basically I ramped down my pressures more
Mm-hmm.
and more and more. But every time I looked at her, she was registering pain, but she never uttered a word to say stop like I had
Mm-hmm.
requested. And it wasn't until a couple sessions down the road, and I don't remember why this became a topic of discussion, but in her life as a child, as an adult, it was never safe to say no to a man.
Yep.
And I inserted my request for her to tell me if something was too much. She agreed to it because she wanted to agree to it. But when it came down to it, she could not tell me to stop. And that was, I mean, that was literally 25 years ago, but it was an earlier influencer of why I chose this approach, why I chose manual therapy to be shared decision making instead of just clinician as expert. And in her case, she wasn't trustable to tell me because of her past traumas. And
Right.
here I was setting her up. Was I re-traumatizing her? Maybe. Was I replaying that tape from all those times when she wanted to say something?
Mm-hmm.
Definitely, right?
Mm-hmm.
And I just think we need to be cognizant of that, whether we're working the oral cavity, which certainly is a potential for real or expressed, or I don't want to say imagined, but for um, trauma or potential for trauma from the past and present, just like anywhere in the body.
Mm-hmm.
And being mindful not only of the potential, but how to work through that, how to work around it, how to get true patient compliance and permission. It's difficult,
Mm-hmm.
but none of our works are easy. Certainly, the mechanics of them aren't easy, but how we envelop them, the meta that surrounds our intervention, I think is a huge driver we need to pay attention to
Mm-hmm.
and modify based on the individual needs of the person in front of us.
I had nursing home patients that could not tell me what day it was, but they could tell me about their visit to the Eastman Dental Dispensary uh, 50, 60 years prior in
Mhm.
great detail. That
Yeah,
is how powerful those experiences are.
yeah.
And the vast majority of people walk into the dental setting fully expecting to to be hurt.
To be heard. Yeah. To be put on threat and guard. And right, most of them are willing to take it because they feel that's a necessary condition to have that work done. But do we
Mhm.
have to present it in that way?
No, we don't. We don't. And I gave local injections when I was living in Colorado, and patients would be stunned that it didn't hurt because I developed a technique and it doesn't have to hurt. I developed a
Mhm.
technique that was purposefully painless.
Mhm.
So again, I figured it out. And that's just a small thing, but you know, look, an injection, a local injection in the mouth should not, it doesn't have to be painful. And there's a lot
Right.
that the practitioner can do to not have it be painful. Yet patients complain all the time about painful injections. And
Mhm.
that's a major trauma,
Yeah.
traumatic trigger.
And there certainly are divisions within what we're talking about as the profession that I use and teach in yours. In my work, I'm going to ask that patient things that I don't know that anybody would ask that in the dental, just as you said, or say yes to it. But for instance, in manual therapy and massage, myofascial release, whatever you want to call it, there are people who do appreciate and seem to benefit from more aggressive, maybe even painful therapies because
Mm-hmm.
something about their past or present said that's necessary. Kind of doubting that you're going to ask a patient, would you like this injection to hurt or not? But
Right.
yet, you know, but at a very a core level, it's including them in this process. Have you had problems with painful injections in the past? And I strive not to.
Hmm.
I think that can be incredibly reassuring to, the pain diverse population,
Hmm.
but also respecting them sufficiently to offer them choice, right? To
Hmm.
offer them the opportunity to influence how you're going to go about the work that needs to be done.
Right. Rather than just, walk in, put it, recline them and, um, and there's so, and, the things, even though you and I are in different fields, the, the stuff
Hmm.
that we're talking about is extremely applicable to both fields. And
Yeah,
that's why I wanted to talk to you today because of
yeah.
these, what did you call it? The,
The meta,
yes,
the meta.
the meta
Yeah,
concepts. But also, I think just as an anatomy nerd, um, that some of my fellow professionals could benefit too from your observations about working in the mouth. And do you have uh, any observations or tips that you think might be helpful?
yeah, yeah. And sometimes online and in after classes, I'll get sort of negative comments that I don't respect. I don't pay attention. I don't teach from a purely anatomical framework like other people in my profession do. If we're talking about base of tongue, for instance, and we're looking at, why a person is having potentially with diminished articulation, oral, airway, et cetera. Some people talk about, I'm going to be hypothetical here, the specifics of the digastric, right? Where
Hmm.
you need to find the origin insertion, understand it fully so that you can isolate that muscle for intervention.
Hmm.
And I get that. It's it's the traditional historical way that manual therapies as well as exercise therapies are taught. But can we isolate a digastric and individually treat that without having a co-influence on the human being? Meaning, when I touch somebody here, I can't isolate the digastric unless I have a scalpel. Because
Hmm.
without that scalpel, sure, I can palpate origin insertion. I can say, wow, digastric feels a little bit tighter than its neighbor. But anytime I touch and I try to intervene on that, there are multiple factors at play why a person responds positively or negatively beyond the simple origin insertion of the digastric. And
Hmm.
that's it's off-putting for some people when we're talking about the softer piece of the reality. I think the softer sounds minimalist, and I don't mean it, because the softer piece is really what we're working with. We're working with a person's response to my touch. There's
Hmm.
enough sensory input from skin and embedded receptors and cutaneous nerves that they could be the receiver and the impetus for change versus what I'm actually doing to the muscle itself.
Hmm.
Um, and I love this confusing uncertainty, multi factor type of explanation for why touch, why manual therapy, why any kind of intervention works beyond just that very narrow silo view of, oh, it's the muscle or it's the, the jaw opening, whatever that might be. And I think that's a tough one when it comes to neurophys, to neuroanatomy, to anatomy itself. Well, it's almost like now, Elizabeth, I don't mean to date you here, but if you're as old enough to remember when anatomy textbooks were, they had those clear plastic or mylar pages somewhere in the middle
Hmm.
where you had sort of, let's peel the layers off the
Yes.
human till we get
Yep.
to the core, right? And when someone says, well, why don't you teach from an anatomical perspective? I used to actually carry those with me and I'll say, well, which layer do you want me to teach from? Do you want
Hmm.
me to teach from the skin, the muscle, the bone, the ligaments, the fascia? Because all of those layers potentially have input into why the problem exists and why interventions might be helpful. You got to pick for me, Elizabeth, which one do you want me to teach from? And then I'll teach from that page.
Hmm.
But in reality, we're dealing with a multi-mylar sheeted human being that
Hmm.
all of those layers, all of those tissues, all of that anatomy may be influential. So why limit yourself by just picking one page?
And that goes back to what we talked about initially. We're treating a whole person. We're not just treating in the dental profession. I'm not just, removing debris from teeth. I'm
Right.
treating an entire human.
Yeah.
And something, the neurology and the of the whole thing too, nerve endings and the nervous system. We are working also with the nervous system.
Yeah. There's a
And
paper that I'm referring back to the meta. If anybody's interested, there's a paper that strongly influenced me when I was exposed to it. Um, And it's written in the speech pathology field specifically to transgender voice, but I think it's so broadly applicable across the spectrum of professions and patient population. And it
Mhm,
was a 2017 paper written by a speech pathologist named Leah Halou, where she's talking about the meta therapy, and that so much of us see the the work as the technique itself, the modality, what we're doing as the principal driver. And what Leah is talking about in this paper is, yep, the therapy is important, the modality, that the intervention is important, but it's the meta being the envelope that we present that intervention with. That's one that takes time to acquire the skill and understanding of the softer pieces around that. And that it's taught to us by patient interactions, by mentors, by supervisor. We learn it, some of it in school, but most of it is how we apply on the job. And
mhm.
it's Leia's contention that, at least the way I read the paper, and because it's mine as well, that the meta may be as influential, and in some cases even more influential, than the actual technique we're using. And I just so strongly support and believe that. And sure, it's scratching all of the biases of me as a human being, me as a professional, as well as the work I teach. But I think there's soft concepts that aren't adequately taught in our education as well as our continuing education.
Right.
We either pick them up or we don't. And, we kind of deflect and say, well, the patient wasn't ready for my work. But maybe it's just me and not being ready to figure out how to build a relationship with this unique individual in front of me.
And the patient blaming and the victim,
Mhm.
the victim blaming, um, complaining about a patient's offensive behavior while while excusing whatever it is, not even looking at my part, not looking
Mhm.
at, was there something I could have done differently? Um,
Yeah.
so I just had an idea. If, say, you had 50 dental professionals, dentists that came to you and, Walt, we want you to, we want to have better patient interactions. How can you help us? What would you say to them?
Yeah. I would start by explaining shared decision making, by explaining the pitfalls that people have with it when they see their work as being so technical that it does take an expert to be able to adequately provide that. Um, and I think we all might see ourselves as a unique setting. Well, no, no, no. I understand that, but my particular role, my training, my education, my function here is a very technical role that patient input shouldn't influence. And, again, I'll go back to some of the simple. Yeah, I'm not going to ask them where they want me to cut if you're doing surgery, right?
Mm-hmm.
But from, when you start really pouring through the shared decision evidence in medicine and dentistry, you're going to see there are a lot of components which can and should include patient input. I use oncology because that was one of the most, I think, the earliest ways that shared decision making was presented, that the oncologist
Mm-hmm.
um, is often looked to as the expert to help the patient decide. And certainly that person does know the data, does know the statistics that, you as an individual stand the best chance of a 5-year survival rate if you pick this particular path of intervention.
Mhm.
But shared decision making is trying to um, diminish clinician bias and trying to equally present the options, even though you feel, as knowing the evidence, that option B may result in a lot poorer outcomes than option A. But the individual should be presented with those choices without bias, and allowed to make that choice as a human being. We all have choice, but yet sometimes we're acting more as convincer or coercer than we
Mhm.
are as really just saying, you know, here are 3 options that people often choose, right? If you ask for my opinion, I will tell you that, but I also want to tell you that some people do beat the odds and live longer than supposed to, and some people want a quality of life that can't be attained if I push on you the one that I think is best. And
Mhm.
again, I'm speaking some naivete here, Elizabeth, because I don't know the exact evidence for shared decision making for dentists and dental hygienists as well. But I think that's part of our responsibility as professionals to keep ourselves updated, not just on the evidence from within that smaller range that we often look at it from, but some of the larger ranges that may at first not seem applicable to us. That's been my biggest life lesson over the last decade
Mhm.
is sort of broadening my perspective, understanding. Because often, for instance, in my profession, a patient is often blamed for not improving, not meeting the goals because, for instance, they didn't do their homework. They didn't do their
Mhm.
home exercise program, right? Which, okay, there's merit in looking at it from that. But how much did I look at that exercise or stretching or whatever regime that I gave to my patient in terms of their own ability and willingness to see it at value, right?
Mhm.
Did they fail? Did they fail because they didn't do what I asked? Or did they fail because I didn't connect with them to find out what they might better wish to do? Right?
Mhm.
There's a big difference there. The
There is.
patient blaming is just such a knee-jerk response. They didn't do what I told them was
Right.
best. But how do I know that I know their answers?
Well, and that's the classic battle in dental hygiene. We all tell our patients they need to floss their teeth. And you know who actually flosses their teeth every day? Dental hygienists. Um,
Mm,
or, people who have had periodontal surgery and have had spent thousands of dollars to keep their teeth.
yeah.
And, so I'm telling this page, we tell the people, you need to floss your teeth. And not looking at the myriad of other things that are affecting this person's oral health, like mouth breathing,
Mhm.
like a lack of saliva, their microbiome. These are all things that have just as much of an effect as not flossing, but
Mhm.
instead we focus on the flaw. You didn't do this, you didn't do that, and that's where that again contributes to this negative vortex. And
And what are the barriers, right? What
right,
are the
why what
barriers that
yeah.
keep that person from, let's stick with that. What is it about me that isn't using dental floss every day? And I think if we can start to have that conversation, sure, it takes time. What are
Hmm.
your barriers? What are your reasons? Is it time?
Hmm.
Is it the floss, um d- okay, I'm going to be completely naive here. And my hygienist always stresses the use of the dental floss, which she uses at the end of my cleaning. And
Hmm.
I use those little flossers, right?
Yep.
I have no idea in the literature if there is such a thing, if those are better, worse, different when it comes to maintaining. But I guess what's missing from my interaction with my hygienist is a validation that, yeah, then you're doing the work you should without, again, super simplistic, but it could be something as simple as that. Here I present the flossing with I'm being presented with the floss, but yet I use a different tool. And maybe it's implicit to me that I should say, is that equivalent to me using dental floss every day? And I just think we can break it down to some of the really basic steps of trying to understand the person in front of us
Hmm.
instead of the data that we're interpreting for them.
I used to say to if a patient comes in and they have pink, firm, healthy gum tissues that don't bleed, I don't care how they got that way. I don't,
Mhm.
I don't
Mhm.
care if you're using, which I love the little flossers too. If
Mhm.
you're using string floss, if you're using an interdental brush, if you're using toothpicks, whatever. Because I'm more interested in the end result, in
Yeah,
healthy pink tissues. But now, the more I read about the oral microbiome, you can have a mouth that appears to be healthy by all, the parameters, but um, not a lot of dental offices will test the saliva for the bacterial count. And
yeah,
these bacteria go into the bloodstream. So I I'm as we start to get out of our silos and start to get toward this paradigm shift, I think that that's going to become uh, a major factor in the dental profession. I'm hoping, because that, I think, it's not invasive, it's not painful, and it gives a lot of information.
yeah. And it could be something as simple as just picking up an article or two on shared decision making, on
Yeah.
metatherapy, on the therapeutic relationship. And doing a deep dive, whether you like PubMed, my favorite is Google Scholar, which
Hmm.
to me is so much more friendly than PubMed. And if you're not familiar with Google Scholar, just go into Google and type in Google Scholar. And what you just found was a narrowed down view of the more general of information available on Google, typically limiting itself to research articles or similar things. And by simply doing a couple search queries for, your specific profession with shared decision making, with
Hmm.
metatherapy, with therapeutic relationship, start seeing how that meta that surrounds the treatment we do might be influenced by understanding more of those peripheral interactions, the psychosocial interactions that we have every time we see a patient.
Yeah. To me, that the psychosocial part of the dental care is so much more important than um the the handpiece, the
Mhm.
which handpiece do I use, how many surfaces are affected, and all this other stuff, because that stuff is you know that stuff is learnable. It's
Yeah,
rote.
yeah,
It
yeah. Going back to that Leah Halou paper, I could just envision a parallel paper written in your profession where, the new grad comes out knowing all of those things of the technical nature of how should be done. But yet, as a successful clinician, it takes time to take those skills and make them broadly applicable. And,
Mhm.
whether or not you read Halou's paper to understand the underpinning of her approach, it's seeing it's so much more than just being a good technician.
Yeah.
It's also being a good communicator, an empathetic participant in the therapeutic process versus the concept of being the applier of the therapeutic process.
Yes. 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 The applier of the therapeutic process. Nobody applies the therapeutic process like dental people.
Yeah. Well, I think you'll find that repeated across the spectrum of the various groups that we encounter on a daily basis, certainly the people that I interact with at my seminars, et cetera, because they're really difficult to unpack that sense of, okay, in the in the manual therapy community, there's sort of a historical norm of tiered learning, a
Hmm.
certain educational model presenting tiered learning classes to eventually so you climb the steps and become an expert, which we all want to be. We all want those
Hmm.
things hanging on our wall in addition to our diplomas and certificates, right? But I
Hmm.
think that implicit with becoming classified as an expert is almost tunnel vision of seeing yourself as that expert, knowing things that others don't. And we do, without a doubt. I'm
Hmm.
not arguing that. But as we move into that expert role, I think we're entering a funnel
Mm-hmm.
which what comes out the end is simply me applying my expertise. And what gets omitted from that funnel are the softer pieces that I
Mm-hmm.
think need to be addressed.
Yeah. It's almost your funnel description. It's almost like the opposite. The technical pieces should be on the and the skinny part, and the
Yeah,
soft, and it should all come out as a soft, a soft thing with the technical kind of sprinkled around the edges.
right. And I
Um,
actually use those two reverse funnels. I have a 2 hour prerequisite that people who are taking my training have to take. And I use the funnels, right? The traditional
yes, I
model is,
remember.
we're going down. Yeah. But maybe it's just about inverting that funnel and opening up to all the possibilities, which is really, it's frustrating for clinicians. Because, first of all, I'm teaching a lot of people who weren't trained in touch-based interventions, how to touch, which is overwhelming and intimidating. And then, wait a minute, you want me to do this new thing with touch plus include patient feedback? It's almost overwhelming. And I get
Mhm,
that. And we sort of, I sort of spoon feed people in the beginning. Yeah, you need to learn to touch, but maybe you
mhm,
don't need to learn to touch quite as expertly as you thought if you include the patient in that model where they can
mhm.
help you determine what's helpful.
When you were talking about oncology, I wanted to mention this. A book that I was instructed to read in the early 90s, which kind of started me on this path, was by Bernie Siegel, called Peace, Love, and Healing. And
Mhm,
the book was about the mind body connection, but he also writes a lot about the experience of cancer patients having with different oncologists.
mhm,
And it spoke to me about, how am I treating these humans that are coming to me? And, because Bernie wanted to empower cancer patients who felt unempowered by the oncology. And, he had many examples of, you know, behaviors by oncologists that were, you know, cruel, downright cruel.
mhm,
And that's what kind of broke this idea open as, as a healthcare provider. How am I, you know, am I how am I approaching these people? How I
mhm.
approach these people makes a huge difference. What can I do different?
Yeah.
So I would recommend that book to now I keep forgetting I'm old and time goes by, but that book was pivotal for me. So yeah.
Yeah. I think it's so nice when we each have some sort of those benchmark books, papers, or experiences that, for me, I've got multiples. And it took a lot for me to transition out of, well, my original way of learning this work, which was called myofascial release, which required me to really agree to the group norms of
Mm-hmm.
it's all about the fascia. We have to do it this way. Oh, don't listen to everybody else because they don't know our secrets. Um, it took, I think well, it took almost a traumatic event that caused me to leave that field and basically forced me to start looking at what other people are saying. And
Mm-hmm.
it was troubling in the beginning because when I started looking what other people were teaching in manual therapy, is completely different from what I was doing or what I had learned, which set up a huge dissonance there. But then I
Mm-hmm.
started to have this sort of informal observation, realizing that when we touch for therapeutic intent, we're all doing quite similar things, even though we sort of categorize as its unique religion almost.
Right.
Um, yeah, which we all like to be a part of a tribe. Um, but I think anymore, my tribe is realizing that there's a lot of tribes with good contributions to the work that I do, the work that I teach, and I'm guessing the work that we all do and maybe teach. And I think that's a hard one for some people because there's comfort in your tribe, um,
Mm-hmm.
but there's also really good comfort realizing that no one tribe has all the answers.
Mm. No one tribe has all the answers.
Which is difficult, whether we're talking about religion or politics or social or healthcare, right?
Hmm.
There's so many tribes, each one with their mantras that sort of get repeated. I see that all the time on all the different groups. What you said to me last time, Elizabeth, about posture and the
Hmm.
tongue. And I mentioned that a couple times since we had that talk last week of that a forward head could be result of a tight frenulum, causing the person to do that for an open airway. I hope I'm translating that properly,
Yes,
what you
that's
said.
exactly right.
But the understanding that if you go into if you go into a dozen other tribes who are talking about forward head, each one has its own reason for it, and each one has its own way to remediate it.
Hmm.
Which, not to discount what you said or anybody else said, but can we all be 100% accurate? And the answer is no, right? You learn that from the frame of reference of your tribe. You figured out ways to make those almost metaphoric explanations have meaning, but the realization that all of those, micro observations may not be perfectly accurate. They might be more metaphoric. And that
Hmm.
really irks a lot of people because I'm basically stomping on basic tenets that you were taught. And I don't mean to do that, although sometimes it is kind of fun sometimes. But
Right.
understanding that, okay, just because we learned that as a fact, maybe it's just, sort of a softer metaphor of how we then explain the entire process, knowing that our process might not be, including myself in that, might not be totally the way. It might be just simply one of the ways.
Mm. Yeah, there's some tribalism definitely in the myofunctional world.
Mhm.
Um,
Mhm.
the dental world, I guess there's some tribalism, but when you're restoring a tooth, I mean, it's pretty cut and dry.
Exactly, right. And I don't mean to say to minimize any of those aspects where people are saying, yeah, but what about and the whataboutism, it applies. There's exceptions to every rule and there's rules for every exception.
Hmm.
Um, I guess it takes an understanding that the world works from a lot of different perspectives. And yeah, I get a lot of good outcomes with manual therapy based on how I think it works. But post hoc fallacy is constantly there. Just because it works doesn't mean it's working for the reasons that I think it is.
Yes, yes. So, yes, just that's great. So we have been talking for an hour and it just
Oh my
flew
gosh.
by. And
Yeah.
I want to thank you so much for joining me today. And I knew this was going to be a great talk. And, I love how, even though, we're in two different fields, there's so much in common. And
Mhm.
I really wish that there was more conversations like this. I wish that more dentists would come to your course and get the bigger picture.
Right. Right. Thank you. Well, thanks for your time because I know the talks that we've had have always been a lot of fun and covering a lot of ground, which is great. And if you want, I can send you some of these references if your
I
viewers
would love
have
that. Thank you.
have an interest. You can drop them in the show notes or however you do that sort of thing. Just to if you just want an overview of some of these concepts, I will send the links if anybody really wants to dive deep into an article and you can't find the full text article. Just feel free to message me from my website, which is waltfritz.com, and I don't mind sharing the full text article with you.
All right. Well, I hope you have a great course and
Thank you.
get home safe. And I will see you soon.
Thanks for having me.